Good afternoon, honorable ministers, distinguished delegates, esteemed colleagues, partners, and participants, all protocols observed. My name is Natasha Gilani, an optometrist by profession, born and brought up in Kenya, and after years of clinical experience, I've brought my experience back to Africa with a mission to something close to my heart, creating an enabling environment for women and girls in Africa. I currently serve as the project manager for the Coalition for Women's Health in Africa, with Africa Health Business serving as the secretariat. And it is a privilege to welcome you all to this third plenary session of the Africa Health Business Symposium, one that asks not only what digital health can do, but what must be done now to ensure that digital innovation truly moves the needle on universal health coverage in Africa. We are currently in a race against time. The clock to 2030 is ticking. And so we must ask, are we leveraging digital health fast enough, bold enough, and equitably enough to close the gaps that continue to define health outcomes on this continent? Because let's be honest, digital health is no longer a future aspiration. It is a current necessity. It is one of the few levers we have that can help us move with speed, scale, and precision. And yet, we still see so many promising pilots that never reach scale. Fragmented platforms, disconnected data, policies without enforcement, startups without support, and most concerning, communities are still left behind. So why does digital health matter for universal health coverage? Because it turns ambition into access, ideas into action, and fragmented systems into connected care, but only if we do it right. Digital health does this by expanding access to care in remote and underserved communities, improving quality through AI, clinical decision support, and real-time data, driving efficiency that cuts costs and reduces waste across health systems, strengthening accountability and transparency, empowering patients as active participants and not passive recipients. So today's question is not if digital health can advance UHC, it is what will it take to scale what works and stop what doesn't? Who will lead, who will fund, and who will listen? How do we ensure digital health doesn't widen the gap, but helps close it? Ensuring that no one is left behind, regardless of geography, gender, or income. And today, we are joined by some of Africa's most visionary leaders in digital health, individuals who bring rich insights on scaling impact and overcoming systemic friction. This session is more than a dialogue. It is a call to action to build a future where nobody is left behind. So let's begin. It is now my honor to welcome our keynote speaker for this session, Mr. Jean-Philbert Nsengimana, Chief Digital Advisor at Africa CDC. Africa CDC is leading the charge in strengthening the continent's health security through digital transformation and guides the development of smart data systems, resilient digital infrastructure, and innovation ecosystems that are vital to epidemic preparedness and the advancements of universal health coverage. Please welcome Mr. Jean-Philbert.
Thank you so much, Gilani, for the nice intro and for stealing much of my speech. Distinguished colleagues, friends, change makers, ladies and gentlemen, all protocols observed. Good afternoon.
Is it on now?
It is a great honor to be here and to address you on this exceptional topic of the role of digital technologies for achieving universal health coverage. We meet at a time when digital health is no longer a promise, it is a necessity. But for it to fulfill its transformative potential, we must focus on what truly matters. So allow me to share 5 things, 5 imperatives that I believe must guide our collective action, what I call the 5 C's of digital health for UHC. The first C is connectivity. Over 100,000 facilities across the continent still lack reliable access to electricity or internet connectivity. But connectivity is more than cables and towers. It is the first enabler of care, especially at the age of AI. Without connectivity, no app, no platform or data system can function. We must declare connectivity a public health need or a determinant of health, as essential as clean water or vaccine. And we must integrate connectivity into our health infrastructure investments, whether through solar-powered clinics, satellite internet, or community Wi-Fi hubs. We must connect care to where people live. Connectivity is not about technology. It's about making care possible in every corner of this continent. This morning, the Honorable Minister talked about the need to multiply our speed, increase our speed by 10-fold if we want to reach UHC by 2030. And I dare say that there is no way you can shift gears so quickly without using technology. The second C is about capacity. Only 27% of African frontline workers have ever been exposed to a digital health training of any kind. So if we're serious about digital health, we must be even bolder about building digital skills. At Africa CDC, we are soon launching the first public health informatics fellowship program to develop a new cadre of leaders fluent in both health and data. Digital transformation doesn't happen in the cloud. It happens in classrooms, in clinics, and in communities. So we must invest in people who will power those platforms. The third C is about collaboration. Today, more than 80% of health projects, digital health projects in Africa are fragmented or donor-led. And of recent, we've all heard what happened, almost an extinction event happening in that sector. We must stop reinventing wheels in isolation. Public-private partnerships are not an option. They are essential. And I'm looking at my brother, Dr. Amit. I'm taking the words out of your mouth. But we must redefine what a good partnership looks like. Shared governance, mutual accountability, and alignment with national priorities. Let's collaborate not just across sectors, but across borders. Let's pool risks, co-invest in infrastructure, and co-design interoperable systems. Let's embrace PPP models that can scale local innovations so that Africa becomes a source of solutions, not just a testing ground. The fourth is about the capital. Less than 1% of digital health investments reach African startups. Most innovations don't make it past to the pilot stage, not because they don't work, but because they don't get the financing they need to grow. We must work together to make health tech bankable. That means creating instruments that reduce investment risks unlocking domestic financing, and helping innovators move from grants to growth capital. Let's go beyond pilotitis. Let's build scalable platforms. Let's develop vehicles, like blended finance, pooled funds, sovereign guarantees that can turn good ideas into sustainable systems. And when you look across the continent, it's not like no one is doing it, but people are doing it in isolation. So we need a platform to share those practices that work so that we can learn from each other faster. Health is not a cost. It is the investment that fuels all other developments in other sectors. Finally, the fifth C is about community. Despite rapid digitalization, only 1 in 3 digital health solutions are designed with the user input. That must change. If our tools are not trusted, they will not be used. If they are not inclusive, they will deepen exclusion. We must design with communities, not just for communities. Let's co-create solutions with mothers, youth, and health workers. Let's translate apps into local languages, deliver education through mobile phones, and embed digital health into everyday realities of our people's lives. When communities are at the center, digital health becomes not just a tool, but a movement for equity and dignity. So let me close by recapping. Connectivity, capacity, collaboration, capital, and community. Then digital health will no longer be an intervention. It will be the infrastructure of health itself. So, before I close, I'd like to extend a warm welcome to each of you here to come and join us in Kigali for the Africa Health Tech Summit, the 4th edition. We want to continue this conversation. It is October 13 to 15, so you can type in your telephone, Africa Health Tech Summit. Last year, I was pleasantly surprised to see that we had 350 participants from Nigeria. Can I, by show of hand, know whether there is somebody here who was in Kigali last year at the Africa Health Tech Summit? Yes, my brother. Thank you so much. So, join more than 2,500 participants from 100 countries to take this discussion forward. Let us move from fragmentation to partnerships, and let's turn partnerships into impact. Thank you so much. Murakoze cyane. Merci beaucoup.
Can we please give him another round of applause? Thank you, Mr. Filbert, for that insightful and thought-provoking keynote. You've clearly outlined how Africa CDC is not only aligning digital transformation with the continent's health security, but also charting a clear path from innovation to scale. Your reflections show that digital solutions are not just enablers, they are essential tools for building stronger, more integrated systems that can respond to both everyday needs and emerging threats. You also reminded us that while pilots have shown promise, real progress towards UHC demands systems that are interoperable, data that is trusted, and infrastructure that is resilient. And through the Africa Digital Health Network, we see a practical model for accelerating collaboration, strengthening governance, and enabling countries to move together and not in isolation. So now we turn to a panel of exceptional practitioners and pioneers, those working at the intersection of innovation, implementation, and impact. Our theme still remains very central, from pilot to scale. How can digital solutions drive UHC in Africa? So I invite you, speakers, delegates, to enter this conversation, not just as listeners, but as co-architects of Africa's digital health future. What will it really take to get from pilot to scale? And if we fail to scale digital health, what will that cost Africa in 2030? So let's find the answers together. Kindly allow me to introduce our moderator for this session, Ms. Saloni Chandaria. Please give her a round of applause. Saloni serves as a project manager for external affairs and leads the Coalition of Blood in Africa at Africa Health Business. And our first panelist is Dr. Maxwell Antwi, Country Director, Farm Access, Ghana. Farm Access is an international organization leveraging digital technology to transform healthcare, financing, and delivery across Africa. Through mobile health platforms, digital financial tools, and data-driven systems, Farm Access is improving quality of care, expanding access, and building sustainable, resilient health systems. Our second panelist is Dr. Caroline Kisia, Africa Director, Project ECHO. Round of applause for her, please. Dr. Caroline leads the strategic growth and implementation of Project ECHO across Africa, advancing the organization's mission to expand equitable access to specialist medical knowledge through technology-enabled learning, using its telementoring model and virtual communities of practice. Project ECHO connects frontline health workers with expert mentors, closing critical knowledge gaps, building local capacity, and strengthening health systems in underserved areas. Our third panelist is Mr. Oluwaleke Jegede, Principal for Solina Center for International Development and Research. Solina Center for International Development and Research focuses on advancing health systems and sustainable development across Nigeria and the broader West and Central African region. The organization partners with governments and stakeholders to design and implement tech-enabled, data-driven solutions spanning digital primary care, immunization, outbreak response, and institutional capacity building. Our fourth panelist is Mr. Paul Buhi, Managing Director, Vantage Health Technologies, the digital innovation arm of Broadreach Group. A round of applause for Mr. Paul. Paul leads the design and deployment of AI-powered, data-driven solutions that strengthen health systems and enhance decision-making across programs in Africa and the United States. The organization supports governments and partners in scaling digital tools that improve decision-making, expand access, and advance UHC. And in Nigeria, it powers the country's largest ever public health intervention, helping to transform healthcare delivery in even the most resource-constrained settings. And our final panelist is Mr. Wilfred Jagi, co-founder and CEO of Vilgro Africa. A round of applause, please. An impact investor and incubator that supports innovative health startups leveraging technology to solve critical health challenges through funding, mentorship, and strategic support. Vilgro helps digital health innovators scale solutions that improve access, equity, and efficiency across health systems. So with that introduction, I'd like to hand it over to the moderator for this session, Ms. Saloni Chandaria.
Thank you, Natasha. And once again, Ekabo, I think I've said that correctly, and Ekasan to everyone joining us for this exciting session on, have I said it correctly? Thank you for joining us for this exciting session on leveraging digital solutions for the attainment of UHC coverage in Africa. Today, we're honored to have a panel of esteemed experts who will help us unpack the many dimensions of this important topic. We'll explore how data-driven health financing is unlocking new opportunities for access and equity, how technology is driving greater efficiency within our health systems, and why strong policy and data governance frameworks are essential to ensuring sustainability and trust. We'll also look at how digital health tools are supporting and strengthening the healthcare workforce, empowering communities and fueling innovation across the African continent. So, to my first panelist, Dr. Maxwell. Data, when harnessed effectively, can unlock smarter, more transparent, and more equitable health financing systems. From enabling targeted subsidies to de-risking investment in healthcare delivery data is reshaping how resources are mobilized, allocated, and monitored. So, what is the role of digital platforms in health financing, e.g., the mobile health wallet and NHIS integration? And what are the lessons from implementing health access programs in underserved communities?
Right, thank you. Let me start by thanking my good friend Philbert for an excellent keynote and use one of the punchy statements you just made about digital is not an intervention but infrastructure. And use that to scope our experience that we have had over the couple of years with the government of Ghana on health financing. Philbert, do I have your permission to use your... All right, thank you. So, just to put it in context, a few years ago, Ghana started its national health insurance scheme. Currently, more than half of all Ghanaians are covered. And the scheme covers about 95% of all diseases in Ghana. So really a very boutique approach towards UHC. All systems of NHIA were manual and paper-based. And I just want you to picture how that system looks like. Just to give you an example, we're working in the northern part of Ghana, and people had to queue for 3-4 days at the National Health Insurance Registration Center to get an insurance card. 3-4 days. So you virtually go to the center and you have stones lined up, and each stone represents a human being who is taking a health break. And people spent, I remember there was a farmer who cycled 10 kilometers, took a whole day to get to the center. And what struck us as the registration team was this guy rode on his bike with a live chicken at the back. And we got curious and we started asking, why did you bring this chicken along? And he said he had information that he would spend 3 days at the registration site just to get a card to access care. So he has brought a chicken along so that he could sell the chicken for his upkeep whilst he queues for 3 days. So this is where we started from. Everything was manual, everything was paper-based. So what we did was we started with the credentialing and we digitalized it. And then we went to mobile re-enrollment and we digitalized it. So even here in Abuja, I can enroll on NHIS without having to go and queue for 3 days at the registration center. But that's not the most exciting part of it. What happened was that when we digitalized the provider side and then we digitalized the membership side, NHIS started having tons and tons of high-quality data. To put that in context, NHIS used to receive 10 million paper claims every year. Just imagine 10 million paper claims every year. You will need a whole Nigerian army to vet that claim. So basically, we're not vetting the claims. We're just paying as and when people requested for them. And then we digitalized that. And so then you had 10 million quality data points coming in to the National Health Insurance Scheme. And then we started asking ourselves, what do we do with this big data? And then we started thinking about, okay, so how can we use this data to make policy? And just to give you an example, we always thought that our biggest problem was malaria until we started looking at our own data. And even as a physician, I was shocked to realize that our 2 biggest cost driver of health in Ghana, and I don't think it's different from Nigeria and Rwanda and Kenya, was hypertension and diabetes. The 2 of them accounted for 25%, only those 2 diseases accounted for 25% of our health costs. It was staggering. It had actually overtaken reproductive health. Reproductive health was around 19%. So this was mind-blowing for all of us. And the question of, so what do we do, resulted in integrating, I'm sure most of you are aware, we integrated family planning into our national health insurance scheme. So, the stop work order, it hit everyone, but not as much in Ghana because we had already integrated family planning services into our national health insurance scheme. But that's not the most exciting part. Let me end with the most exciting part. We started asking ourselves, why do we always pay providers based on volume and not on outcomes? So just to put it in context, if I take an Uber from Lagos to Abuja, and the Uber driver drops me in the middle of the road, and I never get to Abuja, will I pay the Uber driver the same cost as I would if I were to get to Abuja? The obvious answer is no. But that's what we do in healthcare. All health payers pay based on output. So my mom has hypertension. She goes to the clinic every year, every month, every week. Whether the blood pressure is controlled or not, the provider gets paid. So we in Ghana have started re-engineering and looking at clinical outcomes instead of only volume and output. So guess what? Providers submit blood pressure measurements, not only claims. They submit blood pressure measurements and blood sugar measurements along with your financial claims. And the whole concept, we call it value-based care. It's a big word, but I'm just trying to break it down. And then we are saying that, okay, so you get your basic amounts paid. But if the blood pressure gets controlled, you get a top-up. If the blood sugar gets controlled, you get a top-up. Somebody said, yeah, you're opening the system up for gaming. So what do? So then we connect directly to the HMS so that you don't have to tweak the system. And this is opening huge opportunities. Let me just share one of those opportunities and I hand over. So one of the opportunities that this is coming up with is the use of artificial intelligence and machine learning for predicting. So we are now looking at how can we predict personalized health recommendations for patients. So we like the idea of data, but I'm just trying to give you practical examples of what we are exploring with at the national level. So how can we look at Maxwell's blood pressure? Because now the blood pressure measurements are coming in. The blood sugar measurements are coming in. Why should we wait for the person to get stroke? Why should we wait for the person to get renal failure before we intervene? So now the exploration is that can we use machine learning based on historic data to now predict personalized health recommendations and say, Maxwell, looking at your blood pressure over the last 2 years, if you continue taking your medicines, your risk of stroke actually reduces by 50%. Would that help? The telcos do that. The other industries also do that. They give personalized recommendations. We go on YouTube, we go on Netflix, you get all those personalized recommendations. They are way miles ahead of us. How can we employ some of these in our system? So in short, I've tried to give, based on Philbert's nice keynote address, I'm trying to give an example of practically how we move digital from being an intervention, an outside intervention, to being the mainstream infrastructure on which healthcare can be delivered. Let me just end here so that we can take the discussion.
Thank you so much. Thank you for sharing those examples. I move to my next panelist, Paul. So from improving how care is coordinated to strengthening service delivery and enhancing health worker performance, digital tools are transforming the way health systems operate, making them smarter, faster, and more responsive. Would you be able to share with us some of the successes and challenges of having digital tools that improve coordination, service delivery, and health worker performance? If you can share some real-life examples. And then, what is the impact of AI and data integration in improving real-time decision-making?
Fantastic. Thank you very much for that question, and welcome everybody. And what I won't do is go through the theory of 7 layers of transformation and change management methodologies and so on. If you want to do that, you can come to one of my MBA lectures. Right? So what I'm going to do is actually tell a real story of what we're doing now. And in my introduction, you kindly referred to that we're supporting the largest ever integrated public health intervention in the history of Nigeria on our AI platform. So I'll tell a bit of a story there. But I think stories also involve people. So let me also acknowledge a few people that are in here that have also made that story happen. So first of all, we've been working with Global Fund, and we've got my friend and colleague Tajuddin here, who is representing the CCM here, and they've made some of these stories happen. Secondly, what I want to do is acknowledge, and I think what it takes, and we all know that in Africa, the world is full of 10,000 plus pilots, but there are actually very, very few at-scale, country-level, in a country the size of Nigeria, implementations. Very, very few. You can probably count them on two hands. So that takes leadership, and leadership with vision, that was a tongue twister, with vision and also with bravery to say we're going to actually tackle this as a big problem. And in that, I'd also like to acknowledge Dr. Basharoon from NASCAP, who actually took that brave decision to actually say this is the technology and platform we want to deploy across all 37 states for HIV to actually focus down on PMTCT. Then alongside that, another brave and visionary sort of leadership here, we've got my colleagues from IHVN, Institute of Human Virology in Nigeria. I can see Dr. Fati sitting there, Madam Fati, sorry, promoting you again, sitting there at the back, and maybe others. But again, they took a brave decision, and so let me kind of talk into that story. And finally, I work locally with a partner, because we're a company based in South Africa, Washington, and Zurich. So locally, you can't be successful in implementing unless you understand the local context. So we work with a local company who understand the local geopolitics, the actual emotions, the language, the culture, the communication patterns, and how you then implement change incorporating all of this. So I'd acknowledged NHED, who are here, and the M&D from NHED is here, Emmanuel. So let me kind of take you into this story. And just before I kind of kick off, two kind of principles I think I've learned here. That we always sort of think about innovation and in its various forms. We work in 15 countries, and one of the things I would say is that Nigeria isn't actually a consumer of innovation. It's actually a co-creator of innovation. And all of the work we've been able to do is actually co-created with all of those folks that I've talked about, and many others. We worked with many of the other customers here. So never look on, yourselves here as kind of because, consuming innovation from somewhere. It's co-creation that's going on, and there's tremendous, powerful, intellectual, clever people that are in Nigeria that can make that happen. And secondly, and I'll show you now, is that there's also a view that AI is something that's over there, okay? And we've gone through many layers of kind of how we treat data, how we get insights, how we add intelligence, and so on. And then we've come to AI. And many people's minds, AI is something it's going to happen. It's going to happen. So what I want to do is make sure everybody can challenge me afterwards, but I want to make sure everybody knows and sees that AI is here and now. It's been here and now in my career for the last 30 years in various forms, but it's just getting quicker and cleverer and so on. So let me just start, and I hope this clicker works. I'm going to show you a few metrics, because I talked about the largest intervention. Oh. No. Guys, can I have my slides? Okay. This one. Fantastic. So on there, what you're seeing is the size and scale and scope of the project that we're doing with the Institute of Human Virology in Nigeria. It's integrating TB in all 36 plus 1 states with HIV in 4 of those states. So that's where the integration is going on. And when you're actually looking at the size and scale of all of that, we actually also have to work with 11 other companies in there, and you can see them, ANHI, EQs, Society for Family Health, and various others, and some of you folks are in this room right at the moment. So those are the organizations we work with that are actually implementing in the States as well. And so you can imagine, start building some of the complexity of it. So next slide. So again, if you look at the statistics and numbers here, 36 plus 1 states, 35,000 plus health facilities, 11 sub-recipients, 100 plus state executives, 46 technical officers, 100 plus coordinators, and thousands of workers underneath. I hope people are starting to see that this isn't a pilot in 3 states, you know, involving a few people, that this is at national scale. So part of the reason that we actually, that my colleagues at AHBN actually took this brave decision was to say, when you're working at this scale, the questions on the right are the sort of questions you need to be able to answer, and it needs something different. And so what I'm not going to do is go the theory of what we did and how we did it and so on, and what I'm going to start jumping to is actually some of the results we've got. The project went live at the start of this year, so now we're starting to get numbers for comparing the first quarter to the last quarter, and now we'll start getting second quarter and third quarter as well. So those numbers feel remarkable to me. And so in the outcomes, in the TB side of it, we've seen a 40% increase in the number of notified TB cases in the first 4 months of this year compared to last year. Right? So these are the impacts. You know, when we talk about the impact of AI, 86% increase in the number of pregnant women receiving HIV tests and results in the first 4 months. A 5-fold increase in the number in testing in high-risk adolescents. A 10-fold increase in the number of those adolescents receiving HIV-defined packages. Those are programmatic outcomes, okay? Now, underneath, there are also program efficiency outcomes. So using the AI, what we've been able to do, and if you kind of looked at the review pattern for this was a monthly review, and it used to take 3 days. Now, all of that is done, and believe me, there's about 250 to 270 people that get on the call for the monthly review. That all happens in 1 day now, because the data is prepared, the data is available, and what we also do, because all of this is now channeled through DHIS2, which I'm sure you're all familiar with, what we do is we've layered a ChatGPT type chatbot on top of DHIS2. So you can sit there and ask it the questions that need to be answered in the review sessions. And no longer is it the Institute of Human Virology in Nigeria asking the questions, it's actually those 11 organizations that are using the technology to bring their challenges up and to discuss them. Breakthrough number 1 and breakthrough number 2, they've convinced each other to share their performance every month so they can use it as lessons learnt with each other, which would never have happened because they never traditionally shared with each other. And part of this solution is both around programmatic performance and individual performance, and we've made the link, which has never been really made before. So let me describe the scenario. The programmatic indicators aren't improving, but when you look at the statistics of community healthcare workers, they say, yeah, I went there, we've got their GPS location and so on, but the programmatic indicators aren't improving. So there's something not aligned. So what you can now do is drill down using the AI from a programmatic indicators right down to the individuals to actually say there's something wrong here that is not making the indicators change based on the way that you're reporting that you've said to us you've been there. And also part of the issue here was that most community healthcare workers don't really know why they're contributing. So the impact of that was they were leaving. If you look at all of the reports, why is there such a churn in healthcare workers? They don't understand their contribution to the programs, and they don't get supportive supervision. So what we've also addressed is both giving supportive supervision conversations and also building the capacity to do that for them. So hopefully you can, and I could talk about this for 2 hours, as you can tell, but there's a lot of detail behind this. Hopefully this tells you the size and the impact that we're now starting to see on the largest integrated public health intervention in the history of Nigeria. So what I want to do is just finish off with a 4-minute video, and it's not me, it's not any organized, it's people that are talking from the field, from all those states that I talked about, to saying, what has it done for them? And this is also a view of the impact that's happening. So, how do we play that? Guys, can you play the video? Sound? No sound.
Powerful partnership in Nigeria to bolster public health system strengthening through AI-driven solutions. Our collaboration empowers health organizations to achieve cost and operational efficiencies, fostering a performance-driven culture centered on health outcomes powered by artificial intelligence and data. Organizations like AHB are maximizing value from their data through our solutions on their Global Fund-supported program, the largest integrated TB and HIV public health intervention in Nigeria's history.
The silent revolution is underway. At the heart of this ambitious effort lies the M250, the Accelerated Impact Methodology, which has been designed to transform each of the year's 250 working days into a day of measurable impact. With the M250 GAI Assistant, frontline workers can ask questions, get instant analysis and unlock insights, not just from dashboards, but from data that speaks back in plain language. This is more than technology. It is a transformation. Join us as we hear directly from those on the field. Voices from across the north and south of Nigeria, sharing how the M250 is reshaping their work, improving lives, and turning everyday efforts into extraordinary outcomes.
The M250 helps us to monitor on a day-to-day basis, is user-friendly, and the overall intention is to help us carry out effective oversight and to ensure that we meet our targets.
Part of the advantages that I have enjoyed using the M250 platform, all my data domiciled in one place. I'm seeing the data, I'm already able to draw conclusions based on the graphics I've seen on this data.
It has helped me to track the performance of my supported clusters and understand how these people function in the field and know how to support them, find out the loopholes in each LGA and how to support them. When we went for supportive supervision, it was understood that this LGA lacked gross knowledge on proper documentation.
Tells me as a state technical officer to view what the cluster coordinators are doing in their different clusters and also the indicators that we are not meeting our targets.
With the use of M250, it also helps us to know where there are gaps and help us to project plan ahead of time on how to bridge those gaps.
The nature of the intervention we're having, it has been a very big one, but we're navigating well. This particular intervention has come in, handy to ensure that we are able to see what is happening at those facilities. The M250 solution has been helpful in helping us at the state level to intervene wherever we have those challenges and to give the best practices as possible.
The M250 have been able to help us streamline our tracking and also our monitoring of our key performance indicator. That's been a very helpful tool that we've been using at the country office level down to the lower levels. We use the platform now during our cascade meeting to make presentation which is more structured. And quickly we come up with remedial actions. With the M250 at a go, we know where the issues are coming from.
M250 is not just a tool, it is a mindset, a system, a force for performance and accountability into a day of measurable impact. Through real-time program monitoring, a seamless blend of data, AI-powered insights, and a human-centered management structure, M250 empowers over 46 state team leads, 48 HQ executives, and 11 diverse sub-recipients across the TB and the HIV program to focus on what truly matters, which is results.
Thank you, Paul. Thank you. Oluwaleke, I know you have to catch a flight soon, so I'm going to come to you first, and Dr. Kisiya, I'll come to you next. So as digital health advances across the continent, strong policy frameworks and governance are essential to ensure scalability and system integration. National strategies help guide technology adoption, data protection, and public-private collaboration, while issues like interoperability, regulation, and accountability remain critical to success. So with this in mind, could you share your observations on how Nigeria is approaching this space, particularly regarding its national digital health strategy? What are some of the opportunities and challenges you've seen when it comes to public-private coordination and regulation? And how are digital platforms being governed when it comes to service delivery, supply chain optimization, and health financing?
All right, thank you very much. And I would like to start by welcoming everybody again and let you know it's my pleasure to share some of with you. Frankly, I think the policy and regulatory space has evolved a lot over the last 15 to 20 years in Nigeria, with the moving from mobile health initiatives to a more comprehensive framework that's integrated into national health and digital economic policies. We see somewhere back 2009 with the National Strategic Health Development Plan, which features very prominently the digital health and digital initiatives. This is just to take us down the memory lane a little bit, right, to the 58th NCH National Council on Health that sets the tone for e-health strategy in the country, which also culminated in the roadmap for digital health in the country. Down the 2014, we see health ICT assessments, which further lends some credence to the evolution and the development of digital health in the country. I think the most recent of these strides being the National Digital in Health Initiative, which I think there's someone in the audience that's even better qualified to speak about this. Dr. Gbenga Ijadola is there in the audience, who leads that initiative. It is one whereby the government of Nigeria, through the Federal Ministry of Health, sets its plan along the lines of infrastructure, workforce, standards and solution, coordination and governance. And I think this is one stride at finding, at aligning, at enhancing the coordination of the myriad of solutions, digital solutions that is in the health space in Nigeria. To speak a little bit more to that, I think part of the conversations we've had today lends credence to the need for coordination, for leadership at all levels, at the national level, in improving digital in health. The government of Nigeria coming up to set the tone, to set the standard, to set the plan, represents one direction that I think is very crucial for Nigeria as a whole. In line with your question around governance, coordination, interoperability, the standards and solutions aspect of the National Digital in Health answers that in a precise way that I just need to explain what that is. Right? So we've seen efforts to define what the interoperability, the functionality, and the privacy standards for what would govern digital in health in Nigeria would be. And this is extremely important because I think Paul mentioned the Nigerian ecosystem you co-create. There are lots of startups, there are lots of digital tech companies, there are a lot of entrepreneurs and innovators building initiatives in small scales in different sectors, mostly in Lagos, right? So there's a need to align all of these efforts. There's a need for interoperability. There's a need for an entity to say this is the direction in which all the different efforts from the private sector should be aligned. I think you'd agree with me that that entity needs to be the government, just given the differences in interests and impacts and influences and drives and direction of the private sector entities. So the federal government, the Federal Ministry of Health, has over the last 8+ months defined what these standards will be collaboratively, right, through many different sessions, working sessions, conferences, and so on, to say these are the standards we will go by. The next logical step is in operationalizing these standards, right? And I think regarding that as well, there's been the direction along figuring out private sector entities that are most interested, but also closest to the answers, to collaborate with the government in designing solutions to be implemented. This is on the infrastructure pillar of the NDHI body of work. The governance part, I think this is extremely important because I think as we talk about the health sector in Nigeria, we have to appreciate how big it is, not just the Federal Ministry of Health, lots of MDAs, Agency for Control of AIDS, Insurance Authority, the Primary Health Care Development Agency, Disease Control, all of which have their digitization agenda and plans that are at different levels of maturity and different levels of investments. So understand these differences helps to understand the complexity of the digitization agenda of the government of Nigeria. So the governance aspects helps to bring all of these entities to the table to align their interests in a bid to forge the strategic direction for the country on what the digitalization goal should be and how the digitization roadmap should ultimately play out. So I think from a challenges part, they're very clear, but from a solutions part, there's quite a bit in play as well. Thinking about the coordination from the aspect of the governments versus private sector entities, I think this is also very crucial. I already illustrated how crucial that might be in talking about how the private sectors need to gain profits, has to be aligned with the solution, the problem-solving instincts of the government in a way that works for everybody. So naturally, there has to be a forum, for this kind of conversations to continue between the government and private sector on what the strategic direction should be. And there's an example that readily comes to mind, still with the NDHI, where they had called all the telecoms company to the table to say, how can you help us in our strive to digitize all the PHCs, over 30,000 of them, the secondary facilities, the tertiary facilities across the country. And their response wasn't too surprising. It is, let us know what the plan is. Let us know what the direction is, and we can also equally align our investments in that direction, right? Because when those come together, then you can achieve bigger value. So I would say, maybe to summarize very quickly, there's a lot of coordination issues. There are efforts underway to address them, and I think the efforts are going to be along the lines of defining clear goals for what the digitization agenda should be, which needs to be clear to everybody, so whoever needs to invest can align their investment accordingly, and interests are aligned accordingly. Forum to have these kind of conversations on an ongoing basis within government in of itself, given its multiple MDAs, but between government and private sectors as well. Clear accountability mechanisms too, in being clear on what would we have achieved by December 2025, for instance, so we can all ask the questions and see where we may have fallen short. So I think these are the nature of things to do with respect to coordination, and it applies to all instances, right? Be it tech digital solutions on specific program areas or disease areas, or use case for finance, like you mentioned. It's the same principle. We all have to be coordinated and keep talking in a very directed way. I'll pause now.
Thank you. And it's good to see that, the public sector and private sector are working together to come up with these strategies, the standards together. So now I move on to Dr. Caroline, and I think Paul mentioned about the healthcare workforce. They are very critical in the journey towards UHC. But we know many systems across Africa face significant workforce shortages, especially in rural and underserved areas. So Dr. Kisia, could you share your insights on how digital technologies and platforms are being leveraged to strengthen and empower the healthcare workforce in primary healthcare settings, particularly in these remote or hard-to-reach areas?
Yes, thank you very much for this opportunity. It's an honor to be here and to be addressing this particular subject matter. So I'm speaking on behalf of the University of New Mexico Project ECHO Africa team. We are based out of Nairobi and currently using ECHO to build new ways to share knowledge, skills, and mentorship at scale using a proven and powerful digital model. Project ECHO has been working in Africa since 2015, 10 years. The first ECHO program was in Namibia to connect healthcare workers in peripheral settings with infectious disease experts at the capital to address HIV and AIDS. 10 years down the line, the program has been very well assimilated within the Ministry of Health in Namibia and continues to run. And in the time that it was used in Namibia, started off as a pilot, connecting 10 sites. But in a short while, it was clear that it was reducing waiting times for patients to be started on ARTs, and patients were being seen a lot faster while they continued to be under the care of their primary healthcare workers. We know about the challenges of shortage of healthcare workers in Africa. 24% of the disease burden on the continent, 3% of the global healthcare workforce, 1% of the financial resources that are spent on health being spent on the continent to address 24% of the disease burden. And we also know that many of our specialists are focused in our urban areas. Project ECHO is a telementoring model that connects those experts in the urban areas with frontline healthcare workers where the vast majority of our African communities live. And through weekly, bi-weekly sessions, healthcare providers are able to bring challenging cases, the identified challenging cases, for discussion and get input into managing that. 10 years since the first ECHO in Namibia, ECHO is currently has hubs in 35 African countries with 292 active programs. We've had over 1.1 million attendances by over 350,000 unique healthcare workers across the continent. So basically, somebody talked about pilotitis, where you do pilots and then have challenges in scaling things. I would want to welcome you to work with us, a tried, tested, and ready to scale, free to end user solution that's aligned to Africa's universal healthcare goals. It's locally led, it's globally connected. Let me give you some practical examples of some of the work that we are doing. You recall when we had the COVID pandemic, information was required very quickly to get to healthcare workers. Project ECHO had been working with WHO for a long time, and WHO used Project ECHO to make sure that information was getting to the frontline real time. Since then, we are now at WHO Collaborating Center for Digital Learning. We are working closely with Africa CDC on multiple different things across the continent. Part of it right now is the Africa Center for Global Health Security that we had the summit in Nairobi in January, and looking at extending that into West Africa. But aside from that, Project ECHO has worked with both WHO, Africa CDC to address the Mpox outbreak, to address Marburg, to address cholera, to address a number of various emergencies that arise. And the principle is the same: getting information where it's needed, connecting frontline healthcare workers with up-to-date, timely information to be able to deliver on what it is that they need to deliver. So basically, leveraging technology using a simple, low bandwidth technology that works even in resource-constrained settings. When it comes to value add to digital health in Africa, we are talking about various things: equity, expanding access, to ongoing upskilling, to ongoing virtual mentoring for frontline healthcare workers. We are talking about boosting resilience and making sure that information is available in a timely manner. We are talking about using a cost-effective, scalable, and sustainable model. And we use technology that's already in our hands. We use Zoom, we use WhatsApp, we use email, so long as somebody has access to smartphones. And if you come to Kenya today, even community health workers at the front lines have access to smartphones. And so long as you have a telephone signal and a smartphone, you're able to get onto the internet, you're able to get onto an echo session. So no fancy equipment required, but equipment that are already available that make it easy to scale and make it easy to sustain. We partner with ministries of health. We have partnership agreements signed with 20 ministries of health across Africa. We partner with the private sector. We partner with civil society actors. Examples of some projects that we have going: we have a telementoring, equity, and advocacy collaboration for antimicrobial stewardship happening across 7 African countries. Started in August 2023. We've had over 22,000 attendances in that particular program alone. We've got a program that's supporting cancer in 22 African countries. We've got programs that support maternal child health. We've got programs that address the social determinants of health, because we know that unless we address the preventative side of things, things will continue to be a challenge. So my call is anyone who is looking, as we explore digital health solutions that are equitable, scalable, and impactful, I invite you to partner with us. I invite you to partner with us and really look at integrating ECHO into the various digital health strategies that are being developed. Let's work together to build stronger systems, leveraging on tried and tested models on the continent. We know that together we can democratize medical knowledge, empower our healthcare workforce, and make universal health coverage not just a vision, but a lived reality for all Africans across the continent. Thank you.
Thank you. Thank you for sharing what ECHO is doing. And last and not least, Wilfred, Africa's health tech space holds great promise for homegrown solutions, but realizing this potential requires strong innovation ecosystems that can support, scale, and sustain local startups. Many face challenges like limited early-stage funding, lack of incubation support, and difficulty forming the right partnerships. Breaking silos and fostering cross-sector collaboration will be key to driving meaningful progress. So Wilfred, with this in mind, what are some of the challenges and opportunities facing local health startups? And what role do incubators, early financing, and partnerships play in scaling innovation? And finally, how can platforms like the Africa Digital Health Networks help connect the ecosystem and accelerate collective impact?
Thank you. I don't know whether I'm audible. Okay, good. The good thing of going last is I'll be able to build on all the wonderful ideas that have been shared by my co-panelists. And as you said, there are the obvious challenges that we know about: funding, regulatory. So I will not dwell on those, but I'll dwell on a more hidden but obvious challenge that startups face, which is about access. We find that when we talk about our national digital health strategies or our national health AI strategies, the people that we are always left out of these conversations are startups themselves. I don't know how many here in the room are in technical working groups by show of hand. Anyone here who is in a technical working group? Only one. I'm assuming there will be more, but in your TWG, are there any startups? There's no startup, right? And that's the case with many other technical working groups. You find that we meet in these board level meetings, we set strategies and make decisions that will impact startups' ability to scale, but yet we leave them out of these conversations. So the biggest challenge from where I sit is not just funding, but also around access. How do we give startups access? We were joking over lunch with one of the other delegates, and they were talking about startups and innovations being the vaccine against USAID funding cuts, right? Because there's no other, now that funding has reduced, donor funding is going down, the only thing that is going to help hold is innovations and startups. This is a time we need to really start treating them quite well, inviting them in these sessions. I don't know how many startups are in the room. Are there any startups here? At least we can see some 2, 3. We need to have more, you can see. The data is speaking for itself. We need to have more and more startups and innovators in these conversations. That's the challenge number one. The other challenge is around visibility. As my co-panelist was talking about the wonderful project ECHO, and we come from the same country, right? But it took me a flight to come here and learn about what you're doing. Yet we don't have this visibility, right? It shouldn't be the case. We should be able to, in our fingertips, be able to see who is doing what across Africa. And that's what we're trying to do with ADHN. Create a platform, a searchable database where we can be able to see who's doing good work in the continent, which innovations need to be scaled. As you heard from this panel, and there are quite a number of innovations that came out, but that information is only limited to the people in this room, right? We are not having a way of disseminating and creating visibility of who's doing what, so that then we can scale what is working, right? We can't afford to duplicate solutions. Now that funding is reducing, we need to pick the winning solutions and scale those, right? No need to keep putting money to reinvent solutions when other countries already have those solutions. So to summarize, if you forget everything else, just remember 2 words: access and visibility. Those are the 2 most pressing needs of startups that we are trying to address as an incubator, and also now partnering with Africa CDC through ADHN to create that continental-wide visibility platform. And we'll be sharing the QR code shortly about how you can join and be part of this community. Thank you.
Great, thank you so much. I know we're running out of time, but I want to just thank my panelists for your great insights, examples that you've shared of the work you're doing in the digital health space. And like you said, access and visibility, that's the key. I'm going to hand it back to Natasha to close. And I think, is there the QR code? Yeah, it's coming. Okay, yeah, please, everyone, have a look at, scan the QR code, have a look at what we're doing at the Africa Digital Health Networks. It's going to be great. And I think, yeah, Wilfred, we're looking forward to it. You can scan the QR code now. Oh.
Thank you to our exceptional panel and moderator. Your insights have made one truth very clear. Africa is not waiting to be transformed. We're building transformation from within through action, innovation, and collective resolve. So here are some of the key takeaways from today's discussion. We must make access work for all. Digital tools are proving that inclusive health financing is possible. Now we must scale what works and bring these solutions to every underserved community. Efficiency must serve outcomes, not optics. AI and data systems can transform decision-making and service delivery, but only if we invest in practical, scalable applications that serve real needs. Frontline health workers are the backbone of our systems. When we equip them with the right digital tools, like virtual mentoring and online learning, we strengthen care at the community level and extend our reach where it matters the most. Policy must lead and not follow. Interoperability, regulation, and strong public-private coordination aren't optional. They are the foundation to building systems that are trusted, resilient, and ready to scale. So the conversation doesn't end here. It moves with you into the meetings you lead, the policies you shape, and the investments you make. The time is now to build a digitally connected Africa where nobody is left behind in the journey towards universal health coverage. So a huge thank you to our moderator and panelists today. Kindly request our keynote speaker to come on stage for a quick photograph. Mr. Jean Philbert, are you still around? Okay, all right. I think we can just go ahead and take a photograph. I'd like to call upon my colleague, Dr. Bridget Mulwa, for the next session.
Good afternoon. Oh my goodness. Oh my goodness. Daniela, you have to stop giving me the last sessions when people are... However, at work they call me terrorist Gen Z, so I believe I'll do the same to you if you don't respond. Can we try that again? Good afternoon. Okay, you guys are doing well. So, my name is Dr. Bridget Muller, Senior Associate at Africa Health Business. I am a passionate health influencer. Apart from that, I'm a pharmacist who's not practicing, but I'm really passionate about this topic of UHC. So today, I'm privileged to chair the last session of the day. I intend to make it very short and sweet, so that, we can close at a high note for the first session. Are we ready? Perfect. So, as we've heard throughout the day, the journey towards UHC in Africa demands more than just a vision. It demands bold, scalable, and inclusive innovation. We've talked a lot, and I believe it's important to have discussions. But for this last session, it's going to be a fireside chat, and I intend to have a discussion with 3 distinguished leaders in the health space on how to actually turn this insight into action. Are you ready for the discussion? Can you say UHC? Hey, you guys, that's good, that's good. So, I would like to call 3 speakers to the stage, starting with Dr. Lucy Mazaba Mazianga, who's the Regional Director of Africa CDC Eastern Africa Region. Give her a round of applause. Hey guys, she's looking gorgeous today. Please do better. Thank you. Next on stage, I have Dr. Sultani Matendechero, who's the Deputy Director General, Ministry of Health, Kenya. Amazing. As you can see, he's on that side getting ready for the panel. Then, the last speaker, yes, please. The last speaker I would like to call to the stage, Dr. Virgil Lokosu. I hope I didn't butcher this name. He is a director at the West Africa Health Organization. Give him a round of applause. Thank you. Thank you. So, the goal of this session is not just to reflect, again, as I repeat, but to generate actionable recommendation that will move us from dialogue to delivery. And we're going to be reflecting on the 3 sessions that we had today. Thank you. Yes. So our first session today was on financing for health. I believe it all starts with the money. Excuse me, 1 minute, 1 minute. I'd like to call the room to order. Thank you. So it all starts with the money. When we have the money, we set up the comprehensive services of care, right? Then from there, when we have the services, we have the digital to support the services. I think that was a good day to start day 1, right? Thank you. So I'll have a sit here with my lovely speakers. And I'd like to start with Dr. Lucy. Reflecting on the first session on financing for health, could you tell us what stood out for you in terms of the most promising or rather practical approaches to sustainably finance health in Africa?
Thank you very much. Good afternoon, everyone. I hate to be the one standing between you and the swimming pool, so I'll try to be brief as much as possible. Very interesting and insightful conversations, regarding finance. I think we've all agreed that the elephant in the room in terms of health system strengthening and safeguarding health is finance. And I think over the last few months, there's been a lot of discussions around, there's a reduction in ODA, so what next? How do we move? And so I think today's conversation zeroed into what we think will be the best practices. Important to note, though, is that we know what the issues are, and I think we know what the solutions are, but the snag has been on how to implement these solutions. So for instance, the Africa CDC released recently a concept note on health financing in the new era. And in that aspect, we talk about 3 important pillars: innovation, domestic financing, innovation, and blended financing. But what does that really mean in practical terms? And I think today we try to unpack that in the different presentations and discussions. What is evident is that the traditional financial model approaches that we've had and have been using all this time are not working. So we need innovation. And we have a big window of opportunity to, first of all, own the problem, understand it, and find the solution. And I think that in this space, we talked about things like tax, taxing certain products that are not, a big necessity, like alcohol, cigarettes, and things like that. We talked about, somebody reminded us about the Abuja allocation. So the solutions are known. We're supposed to increase the amount of money or resources for health, but we're not getting there. Most of the countries are below 5% against the 15 expected percent. So in short, to say, we need to push the agenda. We need to make sure that we have resources assigned to health. We have a sustainable way of continuously mobilizing those resources. And to do that, you need many players on the table. We need a whole society approach. We need the community. We need the private sector. We need the government itself in this space. And what stood out for me in terms of who needs to be in this discussion and action for health financing, somebody made a comment today about the community health workers. And they said most of the time we do not take into account the resources that are brought in by the community health workers. We always assume they are just there to do the work and we are the ones giving to them. But communities, apart from the community health workers, with the members of the community, have been able over time to mobilize resources to manage the issues around them. So when we're talking innovation, let's not leave out even the people who bring in a smaller amount. We need all the resources put together. And you and I spoke about a concept the women in many African countries have. If somebody wants to improve their kitchen, they'll form a group, put resources together, help one person build up their kitchen. The following month, they'll bring more resources. So the few resources put here and there culminate into something much bigger. So let's not leave anyone behind. Let's have all the resource mobilizers on the table, whether they are community, whether they are big developmental partners, whether they are philanthropists. All of them need to be at the table to discuss and bring to fruition this idea of domestic financing. Thank you.
Thank you so much. Thank you so much, Dr. Lucy. I believe when we were talking about the all of society approach, we talked about the community. And I was telling you about this term that we have in Kenya called chama. Anyone who knows what a chama is? Okay, let me tell you what a chama is. A chama is when, in Kenya, mostly mothers come together to form a group to meet on Sunday after church, and they have discussions over food, but then afterwards, they contribute some money, and someone goes with the money today, next week someone else goes with the money. So it tends to be a happy day for the family that the mother is receiving the money, because they get to buy something new in the house, I don't know, maybe curtains or something of the sort. And it got me thinking, can you imagine if we had a chama, but towards health and for the whole society? I think today the discussions were more on what the ministry needs to do in terms of financing, what the private sector needs to do in terms of financing. But the community is most of the times left behind, and in as much as their money might not be big, I believe even the little that we have can make quite a difference. Dr. Amit tends to use the phrase that we can get more help for the money we have. Now imagine if we added the money from the community, it will make quite a big difference. Thank you so much, Dr. Lucy, for that insight. Now we have money, I think, for health. I'd like to move to comprehensive services and quality of care. Dr. Sultani, we've heard so much about improving access, but you know, at the end of the day, access without quality is still a gap, and I think this is an issue that we have. We have hospitals, but when you go there, you can't get probably, you know, comprehensive services of care, and if they are there, maybe the quality is not there. So, in your view, what's the low-hanging fruit we can act on now to raise the standard of care? And how to ensure that comprehensive services don't become just a checklist, but actually respond to the real needs of people, especially the underprivileged, like the vulnerable communities?
Okay, thank you. Thank you very much for that question. And actually, Bridget, I must confess that I had an idea of this session and I had thought through those low-hanging fruit you're talking about. But the mistake I made this afternoon was to attend a panel that was talking about quality of care. Because I think by the end of that conversation, I discovered that there are no shortcuts. Because, you know, I was listening keenly to the panelists and they were talking about all these structural determinants of quality, you know, so that whereas we are really focusing on access, we want to make sure that services are available, but we tend to forget about the quality element. And for us to be able to achieve that, then there is a whole host of determinants that we need to take into consideration. And I listened to them talking about, structural determinants like human resources, for example, in terms of numbers, in terms of expertise, in terms of continuous improvement and training, just to make sure that the quality elements are upheld. Talking about issues like infrastructure, availability of equipment, issues even like water, electricity, all those infrastructural requirements that are needed. All the way to things like even supply chain, the commodities that we want, the health products and technologies, making sure they are there, they are not expired, they are managed well. Issues around health management, information systems, data. How do we utilize data so that we can plan better, so that we can make better decisions? And all those factors are feeding into quality. You can also even look at the other factors, operational factors, like even, patient-centeredness. There was quite a bit of a discussion around patient-centeredness, issues around, even provider-patient communication. How is the patient being involved even in coming up with those, the treatment plan and so on? Are you taking cognizance of the cultural issues, for example? And I realized it's very hard for us to pick out some and leave out others. Because the moment we do that, then we start losing out on the elements of quality. So the long and short of it is that we really need to make sure that we prioritize healthcare in such a way that we actually ensure that we are prepositioning all those requirements for quality to be available. Because at the end of the day, we are not just looking at outcomes like, the health outcomes like morbidity, mortality, issues around recovery, quality of care, even after people have recovered, the quality of life. How are they living with the aftermath of the treatment? But we are also looking, and this came out very clearly, we are looking at issues like equity of the outcome. The people who are living in rural areas, are they enjoying the same outcome as the ones who are in urban areas? I think one of the speakers talked about the distribution of specialists, for example. Women, are they enjoying the same quality of care as men? Older people and children, younger people, are they enjoying the same quality of care? So it is a very comprehensive package that we really have to look at in terms of being able to achieve all those determinants and being able to deliver on the correct kind of quality that we need. So from where I sit, I think even as we work very hard to make sure that access is achieved, we also have to work harder so that we ensure that the quality that is required, that very high quality of care, is achieved. And I'll conclude by just giving a very good example of what we have experienced in Kenya. We still have very high, unacceptably high maternal mortality ratio, so that you find we have been struggling to bring it down. Yes, we might have a little bit lower than the average, but then we are still so far higher than what we want to achieve in terms of about 70, a maximum of 70 per 100,000 births. But we are still in the region of 300, almost 400 and something, and that is even understated. So we have been working very hard over the last 10 to 15 years to try and make sure that we put what is required in place, antenatal clinics, trying to make sure that information is going out there, and trying to make sure that even opportunities for safe delivery are being put in place, putting all those determinants in place. But then the mortalities are still high. And so we are asking ourselves, what is the problem? Why are they not coming down? Because we are seeing an improvement in the number of visits, ANC visits. We are seeing an improvement in the number of people accessing skilled birth attendants. But the mortalities are still high. And the answer seems to lie in that same place of quality of care. So there are some elements that we are prioritizing over others, and the ones that we are deprioritizing seem to be the ones that are keeping us in that place where we do not want to be. So in a nutshell, we just really have to work hard. When it comes to quality of care, no compromise, no shortcuts. We just have to plan well, end to end, so that we can achieve that for our people. Thank you.
Thank you so much, Dr. Sultani. I think what I've taken from you is one, no shortcuts, and quality can't compromise. I like being practical when it comes to life. Have you ever bought something cheap, yet you had the option of buying something expensive and it didn't work out? Do you think that's what we've been doing? Compromising on the quality, yet we still end up to the same place where we have to start again in trying to improve the health?
Yeah, actually, I think, in fact, in my experience, we end up in a worse place because we try to think that we are saving up, by using, inferior intervention. But then at the end of the day, we find that we are in a worse place. And that is where our problem is. Because when we understand that healthcare is a very important investment, we need it for us to be able to grow. In the morning, my very good friend, Dr. Nzai, who is the chairman of Kenya Vision 2030, was telling us about the pillars of Vision 2030. I even asked him before, what is the third pillar? Because I know there's a social pillar, there's a political pillar, there's an economic pillar. And what we have been struggling to do is to try and place, like we are looking at those pillars as if they are complete buckets. So we try to perfectly place certain issues into their bucket. And we have done that for health. We have placed it in the social bucket. So that's where it belongs. But I can tell you for free, I think there's so much politics in health that you cannot look at it completely within the lens of social pillar only. It can fit in the political pillar more than even most of the other issues that are in the political pillar. Health is arguably the most important enabler for economic progress for countries, but it is in the social pillar. So I think even as we look at those pillars, we really have to look at them in the context of this is probably the entry point, but then for health, it is cross-cutting. So coming back to your issue, I think we really have to relook in terms of priorities, to relook at health so that we don't, bring it down on the priority list. The other day we were having public participation in Kenya. We were going to the communities, just trying to look at the concept of primary health care, involving the views of the people. And we were talking about social health insurance. There were a lot of questions around. Somebody was saying, I paid 6,000 shillings last year. I did not fall sick. So when I went back to claim my money, I was told that it was gone. And we started asking. We know people who have vehicles. They religiously insure their vehicles. And even if they don't get accidents, they don't complain that their money is lost because they understand the concept of pooling. But when it comes to their own health, they feel that it is a loss. So how do we now engage in a way that we make everybody understand that health is the highest priority? It is the one that will enable us to achieve all the other priorities so that they can be able to put a lot of resources in there. We have talked about Abuja Declaration. I don't want to overemphasize, but that is what we really have to think about. We have to give it the best. We cannot afford to give less. Thank you.
I won't even add more to that. Thank you. Now, lastly, Dr. Virgil, I hear people saying digital is the future, but I believe digital is already here. From today's session, maybe what captured your interest most about the digital health potential in transforming healthcare delivery? And I'd like you to speak, on a larger scale, not only on Nigeria, coming from West Africa. I would like to hear the big picture.
Okay, thank you so much, Bridget. Thanks to the organizers of this beautiful event and my colleagues, panelists. It has been a long and rich discussion today. I personally learned a lot about digital health. In terms of the most exciting potential in transforming healthcare delivery, I believe there are so many. They are presented just a couple of minutes ago. But what kept my attention, based on my experience in West Africa, is the way we have used digital health to change the workforce empowerment, especially with community health workers. That was something we really done well in most of the countries I have seen. WAHO has been working with ECOWAS member states to reposition community health. And we understood that succeeding in this event necessarily required that we place digitalization's efforts at the heads of all initiatives we are taking in that region. We need to find ways for the quality of healthcare to reach the last mile of the systems. That was the problem. And digital health infrastructure has been strengthened in most of member states, actually, and it helps us to really reach a vulnerable area. I'm highlighting this issue because our region is actually facing security issues. There are many areas where the official health systems is no more operating. You are aware that we have some countries living the ECOWAS bloc at the moment, so we are still sharing borders with them. And in those areas where we don't have full control of the health systems as before, digitalization is the main and powerful arm we are using to reach out that. And it's my way of also calling attention to the audience here that that effort should continue. The discussion will not stop here. We should keep going on and find ways to go further. Further means to me to be able to translate this effort into our national language. Because in those areas, it's not French and English people are using the most. How our digital efforts are getting translated to an accessible language to the majority of us. That's a question I want to leave you with, and that can be even more exciting to me to hear about that during upcoming discussions. I'll stop here because I saw that the room is getting empty. People are tired.
You're standing in between the people and the pool.
Exactly. So thank you so much.
Yes. So thank you so much to our speakers for the compelling insights and to all of you for engaging with this important conversation. As we wrap up, I'll just like each one of us to just take a minute to reflect on the ideas that sparked your interest today. Maybe connect with someone at the pool now that we're all excited to go to the pool and actually continue the dialogue and ask yourself, what can I do in my role to turn these insights into action? So before we disperse, I'd like to invite the speakers for our photo. And I'll try to do it differently. We'll do a selfie, so I'm really sorry you're going to miss out in the photo. Let's take a photo.
So you need to come. Okay. AI.
Thank you to our fireside speakers
who have been Gen Zized by Bridget. Thank you very much. This brings us to the end of our day one. Thank you for staying till the end.